Today we're going to go over a brief overview of psychopharmacology. Our objectives for today are going to be able to identify nursing interventions for common side effects of psychiatric medications, explain the major classifications for psychiatric medications, identify typical nursing interventions related to the administration of medications, and analyze the potential benefits and other forms of treatments, including herbal supplements, nutritional therapies, electroconvulsive therapy, light therapy, and transcranial magnetic stimulation and vagus nerve stimulation. There's a couple of concepts that psychiatric nurses need to understand. Okay, some symptoms may be present in several conditions. When we talk about our psychiatric mental health challenges, you're going to find that this is really interwoven. There are a lot of medical conditions that share the same symptoms, and a lot of these medications will cover many mental health challenges. So there's many medications prescribed for different diagnoses, and all medications have both desirable and undesirable effects. So of course, sometimes the physicians need to think about if the risks of the side effects outweigh the benefits of the medication's effects for the patient. Nurses need to monitor and document the effect of the medication on the target symptoms. Medications will affect more than just the target symptoms, resulting in unwanted side effects or adverse reactions, and we know this before we give the medications usually. The nurse monitors, documents, and reports any side effects and/or adverse reactions, and the patient's tolerance to these side effects and adverse reactions. Different side effects or discomforts that patients report might be dry eyes, dry mouth and lips. This is a very common one. Constipation, urinary hesitancy or retention, nasal congestion, sinus tachycardia, decreased libido, postural hypotension, photosensitivity, dermatitis, impaired psychomotor functions, drowsiness or sedation, weight gain or metabolic changes. That's another very common one. Irregular menstruation or amenorrhea. A couple different terms to be aware of. The therapeutic index. This is the ratio of maximum non-toxic dose to minimum effective dose. This can be affected by drug tolerance and may be greatly changed by co-administration of other medications. So we need to always be aware of the therapeutic range of some of these medications. Then efficacy, this refers to the drug's ability to produce a response. How well does it work? And then potency, this refers to the drug dose needed for a desired effect. So how potent is the drug? How strong is it? Desensitization, this is a rapid decrease in the drug's effect, versus tolerance, which is a gradual decrease in the drug's action. And toxicity, which is a drug concentration that's harmful to the body. Now, drug tolerance usually breeds drug dependence, as you are compelled to take higher doses for any substantial relief, or else your body will not respond to the medication. There are 4 phases of drug treatment and the nurse's role. The first phase is initiation. This requires a psychiatric evaluation, a physical examination, and laboratory tests. Usually they need a baseline ECG, baseline labs, and baseline vital signs before starting any antipsychotics or psychiatric medication. And we need to monitor the patient's response to the medication. That's in the initiation phase. The stabilization phase, this is the time where we adjust or titrate medication dosage based on the patient's response, assess improvement for the target symptoms, assess any side effects or adverse reactions, give patient education on their medications, on their diagnoses, on the side effects or adverse reactions to look out for, or any toxic effects depending on the medication that they're on. Therapeutic drug monitoring if they need to have labs drawn and what that entails. Any change of drug therapy if needed, and this all happens during the stabilization phase, so we're trying to find that sweet spot to help them with their best medication regimen. 3 is maintenance. Once we have found that sweet spot, our target symptoms have improved, we're going to continue with that medication regimen, give patient education, and assist the patient in monitoring their symptoms. The last phase in the nurse's role is when the medication is discontinued. Some medications require tapering, although some medications are needed for a lifetime and may not reach this phase at all. Now we're going to talk about some major classifications and classes of psychiatric medications. So our first classification we're going to talk about is anxiolytics. And the major class in our anxiolytics is a benzodiazepine. Some examples of our benzodiazepines, and one thing you can use to remember your benzodiazepines is they tend to end in LAM and PAM, okay? So it's going to be alprazolam, lorazepam, diazepam, and clozapam, PAM and LAM. If you see medications that end in PAM and LAM, it's probably a benzodiazepine. Its action is known to enhance GABA. Its side effects, drowsiness, intellectual impairment, memory impairment, ataxia, so their gait is off, reduced motor coordination, sedation or a hangover effect. Tolerance or psychological dependence can occur, so these are highly addictive. They're generally not used for long periods of time because of their risk for dependence. This is usually a PRN medication that's given for short-term relief. In older patients, benzodiazepines can cause incontinence, memory disturbances, dizziness, and increase their risk of falls. There's an increased risk of birth defects in pregnant patients, cleft palate, intellectual disability, pyloric stenosis, and babies can be born addicted to benzodiazepines. It's also excreted in breast milk, so any of our postpartum patients that are lactating and breastfeeding, it's not recommended that they take benzodiazepines. Toxicity can occur with liver dysfunction or disease, so if they have any liver problems, that wouldn't be recommended that they take these either. For substance use disorder, use of benzodiazepines such as Valium and Ativan, which is diazepam and lorazepam, can help prevent symptoms of delirium tremens during acute alcohol withdrawal. So sometimes these are prescribed to help with withdrawal symptoms. Some anxiolytics that are not benzodiazepines, buspirone is one, and this is effective for treating anxiety disorders, especially generalized anxiety disorder, without the CNS depressant effects of sedation or the potential for abuse and withdrawal syndromes. It does not interfere with GABA and does not have a sedative effect, so that is really nice. There's some antihistamines that can be used, like hydroxyzine or duloxamine. These sedative effects promote relaxation. They're not first line, but they can be used with other medication, and they're really helpful in children. Beta blockers can sometimes be used, like propranolol, and this helps relieve symptoms related to anxiety like tachycardia and palpitations and other arrhythmias. Our next classification is antidepressants, and I'm going to talk about 4 major classes: SSRIs, SNRIs, MAOIs, and TCAs. So with our antidepressants, the initial improvement with some antidepressants is within 7 days, but complete relief of symptoms can take several weeks, sometimes 6 to 8 weeks for the full effect as it builds in the bloodstream. And it's really important that you understand that, both for patient education, your own knowledge, and for understanding if a patient's symptoms are being relieved. A slow tapering may be necessary. Antidepressants are generally not discontinued abruptly because of the uncomfortable symptoms that result. Occasional exceptions might be fluoxetine because it'll taper off on its own over 3 to 4 weeks due to its long half-life. These are metabolized by the liver. So what does that tell you about potential lab issues? Um, People may need to have labs drawn once in a while to see how their liver function is, or if they have liver function problems already, it may not be recommended that they take this medication. I want to talk a little bit about neurotransmitters, what they are, what they mean, because you're going to hear some of these medications, how they affect different things in the brain. So serotonin levels, for example, this regulates mood, appetite, sensory perception, attention, and impulse control. Okay, so when someone has a serotonin imbalance, some of these signs might be worry and anxiety, obsessive thoughts, difficulty sleeping, quickly becoming tired, anxious, or aggressive. Dopamine levels. Um, this is involved with our reward and pleasure sensors in the brain. Also has to do with mental alertness, appetite, and motivation. So signs of an imbalance could be lack of pleasure, apathy, low motivation or enthusiasm, likely to procrastinate, mental fatigue, slow response, memory loss, impulsiveness, restless leg syndrome. Norepinephrine, so this stimulates the fight or flight response, energy, arousal. Signs of an imbalance can include brain fog, like inattention or lack of focus, body aches and pains or rapid heartbeat, and then GABA. So GABA functions to restrict and reduce neural stimulation and restore calmness. So signs of an imbalance could be difficulty relaxing, easily agitated or overwhelmed, racing thoughts, tight or stiff body, sensitivity to light sounds, loud noises, or intense stimuli. So talking about SSRIs. SSRIs are examples. These are going to be medications typically that end in teen and PRAM, PRAM, not to be confused with PAM, which is our anxiolytics, but this is PRAM. So fluoxetine, escitalopram, sertraline, and paroxetine. This inhibits the reuptake of serotonin by blocking the transport into the presynaptic neuron, increasing levels of serotonin in the brain by allowing more serotonin to stay in the active space between brain cells. Okay, so it blocks that reuptake and allows more serotonin to stay in that synaptic space. Side effects include headache, anxiety, insomnia, transient nausea, vomiting, diarrhea, sedation, sexual dysfunction, diastolic hypertension, increased perspiration. There's a picture here, kind of a visual to help understand. These little green dots here, the SSRI is the red half moon, and you see where it's blocking two of the uptake sites, leaving one uptake site open. And then these little green dots are serotonin. So more serotonin is able to stay in the synaptic space because there's only, one sensor in this picture of the three that is able to take in serotonin. There is a boxed warning for SSRIs that there's an increased risk of suicidal behavior in children, adolescents, and young adults, or can cause serotonin syndrome. So as you saw in the picture where there are more serotonin levels in the synaptic space, if too much serotonin is in the brain from an overactivity of serotonin or an impairment of serotonin metabolism, this can become a life-threatening condition. So it's important to be aware of over-the-counter medications that in combination with serotonin boosting medications can cause serotonin syndrome. Sometimes over-the-counter medications that promote, stress reduction or calmness or sleep aids, sometimes they include GABA and serotonin, and so it's important to look at the labels on those to make sure that we're not causing serotonin syndrome or that people are just aware of what they're taking. Symptoms of this would be mental status changes, autonomic instability, neuromuscular changes like hyperreflexia and incoordination, nausea, vomiting, diarrhea, and the treatment for this is just simply discontinuing the medication. Our next class to talk about is SNRI. So this is the most common ones that I want you to know: venlafaxine and duloxetine. These prevent the reuptake of norepinephrine and serotonin at the presynaptic site, increasing levels of both of these in the brain. Side effects are very similar to SSRIs, and they increase blood pressure. SNRIs can also treat neuropathic pain, such as diabetic neuropathy and fibromyalgia, in addition to depression or anxiety disorders. Sometimes just increasing those norepinephrine levels in addition to the serotonin levels can kind of just make everyone feel better overall. And so it helps with some of the kind of tricking your brain into helping with pain relief. In this picture here, the gray bubbles are the norepinephrine, the green bubbles are your serotonin levels still, and your SNRI is blocking that receptor site from the uptake of both serotonin and norepinephrine. The next class of antidepressants are tricyclic antidepressants. These examples of these are your leans and mines. So amitriptyline, chlorperamine are some of the common ones. Actions on a variety of neurotransmitter symptoms, including norepinephrine and serotonin reuptake. They're as effective as SSRIs, but they have more serious side effects, so they're not really used as often. They have a higher lethal potential. These have anticholinergic side effects, and these are the most common side effects: sedation, orthostatic hypotension. And then a mnemonic you can use to remember the anticholinergic side effects are red as a beet, dry as a bone, blind as a bat, mad as a hatter, hot as a hare, full as a flask. And what does that mean? It means that they're flushed, they're dehydrated, blurry, confused, flushed, high temperature, and urinary retention. And those anticholinergic side effects make this a less desired antidepressant to use. And that really goes hand in hand with those tricyclic antidepressants. The next class, the MAOIs, the monoamine oxidase inhibitors. Examples for these, phenelzine, isocarbazide. The way these work, they break down neurotransmitters. By blocking this enzyme, there are more transmitters available to accept serotonin, dopamine, and norepinephrine activity in the synapses. Side effects, however: dizziness, headache, insomnia, dry mouth, blurred vision, constipation, nausea, peripheral edema, urinary hesitancy, muscle weakness, forgetfulness, weight gain. It can cause a hypertensive crisis, which is when interacting with tyramine-rich foods. So really what I want you to take from this with the MAOIs is that they have to have a diet that's very strict, and they have to be careful of tyramine-rich foods. And there are many foods that contain tyramine. There is a picture here on your slide. Everything in this slide here are tyramine rich. Aged cheese, processed meats, different breads, aged wine, nuts. All of these things need to be avoided. Things that are okay for them to eat would be ideal: yogurt, eggs, dairy, shellfish. Shellfish like shrimp are really the only fish that are okay with taurine-rich foods. And we'll discuss more about these dietary restrictions in class. Our next classification are the antipsychotics. There's two different types of antipsychotics. So there's the typical or the first generation, and then there's atypical or second generation. I like to think of this as like the first generation iPhone comes out and has a lot of bugs and they're still working things out. So the second generation comes out and it's much better, so people stop using the first generation phone and they start using the second generation phone. Okay? Kind of the same idea with these medications. So the first generation comes out, they're the zines, so Azine, with the exception being the thiothiazine and haloperidol. So Haldol is a first generation antipsychotic. It's a typical first generation antipsychotic. And any of your zines. Atypical second generation antipsychotics are penes and dones. So clonazepam and risperidone, um, penes and dones. And you can see that on the list here with very few exceptions down at the bottom. And I did put those in a different color so you could see that, 97% of the time you're going to be able to identify these medications by the last few letters of their names. So with the typical first generation antipsychotics, they have these side effects, okay? Extrapyramidal side effects, which include tardive dyskinesia, which is an abnormal involuntary movement such as lip smacking, tongue protrusion, chewing, blinking, and grimacing. Akinesia, which is an uncomfortable restlessness, kind of like feeling like you're crawling out of your skin or like a restless leg syndrome. Pseudo-Parkinsonianism is a slow shuffling gait, a stooped posture, pill-rolling motions in their hands, and a mask-like expression. Dystonia is muscle stiffness or rigidity, and that can kind of happen all over the body. When you see these extrapyramidal symptoms, administer reversal medication as ordered. An example for that would be Benadryl, and Benadryl is very effective at reversing these side effects. You do need to know what these side effects are and how to identify them. These first generation medications can also cause something called neuroleptic malignant syndrome. If this occurs, you need to stop all antipsychotic medication, notify the physician immediately of seizures. This comes on rapidly. The symptoms cascade very quickly. It presents with high fever, confusion, and that's something that needs to be reported right away. Haldol specifically is known to cause neuroleptic malignant syndrome when given in high doses. Now our second generation atypical, so now we've got better, newer medications, right? But with these medications, patients with diabetes, they need to monitor their glucose very carefully. And if given clonazepam, this can cause a granulocytosis and severe neutropenia. So we need to make sure that we have a white blood cell count before giving this medication, and occasionally while taking the medication, the white blood cell count needs to be checked, and an absolute neutrophil count. Olanzapine may cause delirium and sedation due to potential adverse reactions. So never stop any of these medications abruptly unless there's a life-threatening signs and symptom that's occurring. Okay, so if the patient's having trouble with the medications, it may just be that they need a different dose. So never stop them abruptly. If the patient has had trouble complying with the treatment in the past, a long-acting injectable medication may be the best option, and we do have those. Atypical antipsychotic medications are not FDA approved for treating behavioral disorders in elderly patients with dementia. Agitation and hallucinations are typically relieved during the first few days of treatment. May take weeks for delusions to subside. So that's going to be more with schizophrenia. So someone with schizophrenia, we may start them on an antipsychotic. Their agitation and hallucinations will be relieved right away. But if this is taken for delusional disorder or if they have delusions for schizophrenia, it will take a few weeks for those to subside. Mood stabilizers or anti-manic medications. Lithium is the gold standard for treatment for a mood stabilizer. And this is when we really talk about bipolar disorder. So the indication for this is mania, which can be, mania can happen over different mental health challenges, but most primarily with bipolar disorder. The onset of lithium is 5 to 7 days, but may take as long as 2 weeks. It's excreted by the kidneys. It has a therapeutic level of 0.6 to 1.2. If it's greater than 1.5, then it's a toxic level. Normal side effects are thirst, metallic taste, increased urinary frequency, fine hand tremors, drowsiness, and mild diarrhea. So think GI symptoms, a very fine tremor, and a metallic taste in the mouth. Those are normal symptoms for lithium. Lithium monitoring, blood levels for toxicity need to be checked. Severe diarrhea, vomiting, confusion, muscle weakness, lack of coordination, tinnitus, ataxia. So if they have toxicity, I want you to think cognitive symptoms. So confusion, ringing in their ears, if they're having tonic-clonic type spasmings, ataxia, so they're walking and their gait is off. If any of these things are happening, lack of coordination, we're going to hold the drug. They don't need to necessarily be hospitalized or anything like that. We hold the drug, draw a level, see where they're at, and adjust the dose as needed. We're going to check their renal function to see if any kidney damage is possible that hasn't been addressed. Check their thyroid function because it's possible there could be an alteration after 6 to 18 months. And then any alterations, you may see symptoms of dry skin, constipation, bradycardia, hair loss, or cold intolerance with thyroid function issues. And lithium really needs to be avoided if pregnant or breastfeeding. Anticonvulsants like valproate, rapidly absorbed, peak serum levels in 1 to 4 hours, a liquid form within 15 minutes to 2 hours. So this works really quickly. Side effects are GI disturbances, tremor, lethargy, weight gain. Food appears to slow the absorption, so it's best given on an empty stomach. This is a mood stabilizer for bipolar, but also treats epilepsy and migraines, and the trade name for this is Depakote. Lamotrigine. Side effects are skin rash, sedation, blurred or double vision, dizziness, nausea, vomiting, and other GI symptoms. In rare cases, severe life-threatening rashes occur within 2 to 8 weeks of treatment, highest risk in children. Immediately discontinue if a rash is noted, also used to treat epilepsy, off-label use for depression, and the trade name for this is Lamictal. Carbenzapine is an anti-seizure neuropathic medication when used in combination with antipsychotic, treats schizophrenia or bipolar disorder. So not to be confused with the pene in the antipsychotic, this is a mood stabilizer. So variable absorption reaches peak level in 2 to 6 hours. Side effects are dizziness, drowsiness, tremor, visual disturbance, nausea. Adverse reactions, rare aplastic anemia, agranulocytosis, severe rash, rare cardiac problems. The trade name for this is Tegretol. Other biologic treatments, so non-medical treatments or medication treatments we can use, phototherapy, which exposes the person to a very bright full spectrum light which has been shown to improve and relieve symptoms of depression for a significant number of people with seasonal depression. ECT, electroconvulsive therapy, which is used to treat severe depression, which is unresponsive to other methods. And that's important. They have to have already tried therapy and medication before they are eligible for ECT. Side effects include short-term memory loss, fatigue, loss of appetite, which is all temporary. Melatonin can be used to treat insomnia. Transcranial magnetic stimulation. This is similar to ECT in how it works, but it's without the side effects. It's used for treating depression. Vagus nerve stimulation is an adjunct for severe depression in adults unresponsive to 4 or more adequate antidepressant treatments. Some common reasons for non-adherence of medications. Some people are uncomfortable with side effects. This is the most common reason, so they just stop taking the medication. Lack of awareness or denial of their illness, stigma of taking medications, or they simply start to feel better. And that is very common as well. And people will take their medications, they start to feel better, so they stop taking their medications, and then of course they have a relapse. They might be confused about the dosage or timing. They may have difficulty accessing their treatments, or they may have comorbidity of substance abuse. So how do we improve adherence? Sometimes there's long-acting injectables we can give that are once a month or once a week. Tablets embedded with digital adherence assessment device to see how things are working. Family education, psychoeducation, assess for interfering factors and develop plans to address them, like why are they not taking their medications. Maybe they just need an automatic medication dispenser on their kitchen counter next to their coffee maker. And that is all I have for you for today about psychoactive medications.